Whether NACT or NACTRT is the ideal neoadjuvant therapy still remains an unresolved issue. The landmark cross trial provides level 1 evidence for both adenocarcinomas and squamous cell cancers. The overall study population experienced a doubling of survival from 24 to 48 months, and on subset analysis, squamous cell cancers had a very robust response, their overall survival jumping from a baseline of approximately 20 months to 80 months approximately with the use of NACTRT. Adenocarcinomas also responded significantly but not as robust as SCCs. We have evidence for the use of NACT or periop chemotherapy, again for both squamous and adeno, Boonsra and allies, and 30% of study population of MRC, where squamous cell cancers had a survival benefit with doublet chemotherapy. The other trials had adenocarcinomas and experienced a similar survival benefit with chemotherapy, NACT or periop chemotherapy. FLOT4 compared FLOT with ECF and achieved an overall survival of 50 months. Just to compare, the median overall survival for adenocarcinomas on subset analysis in the cross trial with NACTRT was 43 months, and in FLOT4 it was 50 months. So we have evidence for NACTRT for adeno and squamous. We have evidence for NACT or periop chemo for adeno and squamous. So which one is ideal? Which one is better? So there have been several meta-analyses trying to answer this question. At the time of this meta-analysis by the Australasian GI Trials Group in 2011, there were not enough trials that compared these two options head to head. Their conclusion was that yes, NACT offers a survival benefit, NACT-RT offers a survival benefit. It is not possible to compare these two head to head in terms of survival, but in terms of treatment related morbidity and treatment related mortality, NACT-RT fared slightly worse. They had a higher morbidity and mortality treatment related. There, subsequent to the publication of this meta-analysis, there were a lot of other trials, and in this individual participant data network meta-analysis by the Manatech-2 collaborative group published in 2023, there were 4 trials which compared these two therapy options head to head, which included almost 500 patients. And very surprisingly, there was no difference in terms of overall survival or disease-free survival or the risk of local recurrence between the two therapy options of NACT and NACT-RT. We would tend to believe that NACT-RT should cause a lower local recurrence compared to NACT. But in this meta-analysis, this was an individual participant data network meta-analysis of randomized control trials. There was no difference in terms of local recurrence or DFS or even in overall survival between the two therapy options. 4 trials deserve mention. NEORIS 1, which evaluated both adeno and squamous, comparing neoadjuvant chemo and neoadjuvant chemoradiation. Their primary endpoint was not overall survival, it was pathological complete response, which was significantly higher in the NACT-RT arm. R0 resections were also higher in the NACT-RT arm, but these did not translate into a survival benefit. There was no difference in overall survival between NACT and NACT-RT. NeoAegis evaluated esophageal adenocarcinomas. We know MAGIC was the standard of care during the earlier part of this trial, and FLOT then subsequently became the standard of care when it came to chemotherapy. And CROSS was also an accepted standard of care. So this trial compared these two accepted standards of care, MAGIC or FLOT versus CROSS. And in the preliminary results, addition of chemoradiation, addition of radiation over and above chemotherapy did not provide a survival advantage. there was no difference in survival between NACT and NACT-RT. The results of this trial is eagerly awaited. Next trial, a Japanese trial, which evaluates squamous cell cancers in a three-arm randomized controlled trial, a doublet, two arms with NACT and a third arm with NACT-RT. And another trial, which is eagerly awaited, is the ESOPEC phase 3 randomized controlled trial, which compares cross with FLOT, two well-established standards of care. So, until these results are published, we cannot be sure. But it is fair to conclude that if there is a survival benefit of radiation over and above NACT alone, it is likely to be small. When we see NCCN guidelines, National Cancer Grid India guidelines, ESMO guidelines, for adenocarcinomas, we have both NACT-RT and peri-op chemo as accepted standards of care. It's very clear because we have cross to support NACT-RT and we have FLOT and MAGIC to support NACT. Squamous cell cancers, only neoadjuvant chemoradiation is given. NACT or peri-op chemotherapy is not given as an accepted treatment option for in NCCN and ESMO guidelines, but though we know that guidelines are not verbatim management rules, they are guidelines, broad roadmaps. So we have ample evidence from cross trial to support NACT-RT where squamous cell cancers had a very robust response. Their survival almost jumped 4 times. But the golden question is, if a patient with a squamous cell cancer of lower esophagus or mid esophagus due to some reason cannot receive radiation, enlarged gastrohepatic nodes or disease extending till the G junction where there is a risk of gastric conduit radiation that's concerning. So, can we offer only neoadjuvant chemotherapy for squamous cell cancers of esophagus? The answer is yes. And do we have evidence for that? The answer is again yes. So, as we saw here, in this trial, which evaluated only SCCs, there was a survival advantage with the use of neoadjuvant chemotherapy. In 30% of study population of MRC also were SCCs, which had a survival benefit with the use of neoadjuvant chemotherapy. And again, 30% of study population of NEORES-1 were SCCs, where the direct head-to-head comparison has shown there was no difference in survival between NACT and NACT-RT. So yes, agreeing to the guidelines for both squamous and adenocarcinomas of esophagus have to be treated in different ways, and especially thoracic esophageal cancers and G junction cancers have to be viewed as two different diseases rather than a single disease in different locations. Saying all that said and done, for adenocarcinomas, both NACT-RT and peri-op chemo are accepted standards of care from these trials. And for squamous cell cancers, we tend to prefer chemoradiation. In the rare instance that radiation cannot be offered to a patient, NACT can be offered as an alternative standard of care.